Good evening. Welcome to Pandemic Perspectives, Week 2. If this is your first time joining us, my name is Amy Finley. I'm the Dean of Students at the University of Michigan-Dearborn. I am so pleased to welcome you to tonight's presentation, and welcome back to all of you who joined us last week. Tonight is the second in our exciting 6-week series led by faculty from a variety of disciplines across the university. Over these 6 weeks, we will have the opportunity to learn about pandemics from a wide variety of perspectives. I look forward to sharing in this journey with you. In the audience tonight, we are joined by a variety of students, current and incoming, alumni, faculty, staff, and community members as well. We are grateful that each of you is here, and we hope this is a phenomenal experience for you. At the conclusion of tonight's presentation, our presenters, Dr. Paul Draus and Dr. Jacob Napieralski, will be answering a few questions. So please note that you will be able to submit questions in the Q&A bar at the bottom of your screen. I'd now like to share a little bit of information about our presenters. Paul Draus is a professor of sociology in the Department of Behavioral Sciences at the University of Michigan-Dearborn. He also directs our master's program in criminology and criminal justice. From 1992 to 2000, Dr. Draus was a public health field worker specializing in tuberculosis control, first in New York City and then in Chicago. He earned his PhD from Loyola University in 2001, and he is the author of Consumed in the City, Observing Tuberculosis at Century's End, Temple University Press, 2004. He regularly teaches courses in medical sociology and urban sociology, and the Inside Out Prison Exchange Program course, which brings university students into direct dialogue with incarcerated students. Dr. Draus has published numerous articles on health behaviors and social contexts related to substance abuse, from crack cocaine in small towns in Ohio to heroin and street sex work in the city of Detroit. His most recent research focuses on the relationship between neighborhood landscape change, urban ecology, and the health of marginalized communities in Detroit. Jacob Napieralski is a professor of geology in the Department of Natural Sciences at the University of Michigan-Dearborn. He is director of our certificate program in geographic information systems and director of the master's program in environmental science. Dr. Napieralski is a broadly trained geospatial scientist with expertise in physical geography, water, and urbanization. He received his PhD from Purdue University in 2005 and joined the University of Michigan-Dearborn as an assistant. Since then, he has published 25 scientific articles on a wide range of topics. He was also honored to be a U.S. Fulbright Research Scholar in Cyprus in 2012, where he collaborated on several exciting soil and water conservation projects. He teaches courses in geospatial technology, geology, and environmental science. His teaching also includes an international field course, which has traveled to 4 different international destinations, such as Iceland, Cyprus, Puerto Rico, and Montserrat. He received UM-Dearborn's Distinguished Teaching Award in 2011. His more recent research focuses on the impact of urbanization on water resources and on urban landscape change in Detroit, among other cities. When not working, he is either traveling with his wonderful wife and 2 boys, watching soccer, or having a beer with Dr. Paul Draus. I am so grateful to have both of these wonderful faculty with us here tonight, and I would now like to turn it over to Dr. Draus.
Good evening, and thank you for the wonderful introduction, and welcome everyone to week 2 of Pandemic Perspectives. We're going to be telling you a story tonight, or actually a couple of different stories, about things that happened a long time ago and about things that are still happening today. So the story is going to take a few twists and turns, so please hang with us, and hopefully at the end, we'll arrive somewhere meaningful for everyone. So the story starts with these images. This image of a water pump on a street in London, and this map of that same street in London. And the significance of these 2 images is something that we're going to be talking about today, and by the end of this presentation, you'll know a lot more about this pump and this map and why they are so significant for us today. And so this is a little outline of the ground that we're going to cover in today's presentation. We're going to talk a little bit about the disease cholera and epidemiology and what that is. We're going to talk about John Snow and the legendary Broad Street Pump. And we're going to talk about epidemiology in terms of its different uses, its descriptive dimension, its analytic dimension, and its applied dimension. And we're going to look at some examples from tuberculosis to COVID-19, beginning with the discussion of cholera. And then we're going to end with a note of hope and a note of caution. So I wanted to say a few words about what epidemiology is. In this era that we're living through with COVID-19, a lot of us have been hearing a lot about epidemiology. So many of you are probably by now aware that what epidemiology is the scientific study of patterns of disease, illness, and injury in population. So that's what makes epidemiology distinct from medicine. It's focused on health and illness in populations, not in individuals. And it also forms a scientific basis of public health and preventive medicine. So some of the uses of epidemiology are to assess the health of populations, first of all, to guide individual decisions, like, for example, right now, whether or not you should visit California or not, completing clinical pictures for clinicians or physicians, and also searching for causes of disease or illness or injury. And it's that last area that we're really going to focus on next. So I don't know how many of you out there are aware or know anything about a disease called cholera. Today we know that cholera is caused by this organism, which is called Vibrio cholerae. It's a bacterium which causes an acute diarrheal disease, which results in profuse watery diarrhea, vomiting, and leg cramps, causing rapid loss of body fluids, leading to dehydration and shock. And without treatment, cholera can lead to death in less than 3 hours. So cholera is a terrible disease that has afflicted humanity for a couple of centuries, and it continues to afflict the world today. This is an image from Haiti in 2010 following a devastating earthquake. There was an outbreak of cholera, the largest outbreak of cholera in this century. It was actually caused by United Nations peacekeepers who were camped in Haiti responding to the earthquake, and they were from Nepal. In Nepal, there was an outbreak of cholera taking place at the time, and unwittingly, by discharging human waste into the nearby river, the UN peacekeepers managed to start a cholera outbreak in Haiti, which ended up resulted in over 600,000 cases and over 8,000 deaths. So we now know that this is what causes cholera, this organism, Vibrio cholerae, and these types of environments that you see in this image, especially where there's a lot of untreated water and human waste. So cholera is usually transmitted through fecal-oral transmission. Now, cholera, as I mentioned, has a long history with humankind. This is a map from the 19th century showing the spread of cholera from India, where it was first identified as a sort of a major public health problem in the early 19th century, spreading into Asia, throughout Asia, and eventually into Europe. By the 19th century, cholera was well known in urban centers, both in Europe and in the Americas. This is an image from Paris in 1840. Detroit actually suffered 5 major outbreaks of cholera in the 19th century, beginning in 1832. But at the time that cholera was sweeping through urban centers and areas of dense population in India and Asia and into Europe and the Americas, the causes of cholera were not well known. I told you earlier what causes cholera. We now know that. And of course, we can easily think that this is something which is a matter of common sense. But in fact, it was not. And at the time that cholera was sweeping through Europe, the predominant theory as to the causes of cholera had to do with something called miasma. This is a passage from Edwin Chadwick's report on sanitary conditions in London from 1842. And you can see here that Chadwick, in writing the various forms of epidemic, endemic, and other disease, caused or aggravated or propagated chiefly amongst the laboring classes by atmospheric impurities produced by decomposing animal and vegetable substances, by damp and filth, and close and overcrowded dwellings. This is basically, sometimes this is called, or this was called, the theory of miasma. Miasmas were believed to be poisonous emanations from putrefying carcasses, rotting vegetation or molds, and invisible dust particles that were believed to enter the body and cause disease. So why did everybody think at the time that miasma was the most logical explanation for diseases such as cholera? Well, it partly had to do with the places in the populations that were most affected by cholera. This is a scene from the Golden Square area of London. We're going to be learning more about that area of London a little later on in the presentation, showing the types of very, very overcrowded conditions in which people were living, especially poor and laboring classes in London. Often there were animals and human beings living side by side, and waste was everywhere. Human waste was everywhere, and therefore the odors, as you can imagine, were quite strong. And there were lots of reasons why a person might assume that the odor had something to do with the illness that was attributed to the area. But even though this seemed to make sense in general, it didn't necessarily help in terms of finding specific sources of specific outbreaks of disease. So this is a cartoon from London in the 19th century showing the London Board of Health hunting for cases, after cases of cholera. And you can see these men in their black suits sniffing everywhere to find where the odor was strongest, for they could figure out what was the ultimate source of the disease. So this was actually not successful, right? So even though in the aggregate, and Dr. Napieralski will talk more about the investigations that were done of the miasma theory and of a different theory of cholera's transmission, this explanation was not sufficient in many cases. So into this picture there enters a man named Dr. John Snow. And it's not this John Snow, who some of you may be familiar with. It was actually this John Snow. So we're going to talk about this John Snow and his theory that cholera was in fact caused by contaminated water. Now, again, from our position today in the 21st century, we think this is simply common sense, but at the time it was not. And many people thought that John Snow knew nothing, right? That it was very clear that miasma was the cause of cholera, and his theory, pardon the pun, did not hold water with them. So in order to test his theory, Dr. John Snow engaged in a very detailed investigation of 2 cholera outbreaks that took place in London in the 1850s. And I've been teaching about this case for years in my medical sociology class, when one day I was talking to my colleague, Dr. Jacob Napieralski, who teaches geography and geographic information systems. And he told me about a book called The Ghost Map, which was all about Snow's investigation of cholera in the 1850s. And so Dr. Napieralski is going to take us through some of the twists and turns of that very detailed and complex investigation that was undertaken by Dr. John Snow in the 1850s.
All right. Well, this is my chance to say thank you very much for giving me some time to talk a little bit about my expertise, which happens to be somewhat in geography. And so I'll start off with a statement from the Center of Disease Control and Prevention, which simply says geography is a study of how the world differs from place to place. And this is using a geospatial perspective, which is my expertise. This is where I come in. And this means that it focuses on place and space, looking at what, where, and why phenomenon occur. And a lot of times I tell my students, it's simply the science of where. And this is right up the alley for an epidemiologist to ask those types of questions. And maps end up being a critical component to what we use to answer questions that are spatial in nature. So as Dr. Draus says, I will talk a little bit about John Snow, who I find an absolutely fascinating character. And if we go back to the 1850s, London as we know it today did not exist. It was actually a densely populated urban experiment, I guess. So 2.6 million people packed into an area. But this was an area that was not well prepared to have this many people, so they didn't have a structure for handling wastewater. They didn't have a system for managing fresh water and distributing that equally to everyone in the city. And of course, because the Industrial Revolution was beginning, they also had lots of smog, they had lots of air pollution, and as Paul Draus said, lots of smell. So this also created environments that was optimum for outbreaks, something that we still experience in developing countries where perhaps they don't have a modern system for managing these very basic variables. Okay, so this was a optimum environment for these breakouts. Between 1832 and 1866, there were at least 4 major outbreaks in London, leading to the death of tens of thousands of people, including 1848 to 1849, which was responsible for at least 14,000 people. And usually when this happened, this scared residents and they packed up and they fled the area. And again, most people associated the stench, the smell in London as being the transmitter for this illness, this disease. So on your screen, you can see the data. So we love looking at curves now. So in the last 6 months, everyone's become experts on evaluating curves. And this is an example of data from 1849 that was compiled for the City of London that shows in the blue line, the death rates as caused by, identified at least by cholera. And then in the yellow down at the very bottom, you can see that those are death by diarrhea. So 2 painful ways to go. Interestingly note, the lines that you see scribbled across, so this is a calendar from January to December, and you can see that these lines are actually meteorological data. So automatically they're making this association that there's something atmospheric that's driving these deaths. So what we were able to do after an epidemic is then plot data. And so the map on your screen, I love speaking with maps. And so this map is a beautiful map because it shows where you have all of this action with cholera happening. So the dark blue areas indicate where deaths occurred. So it's actually a very sad map, but it's a fascinating map because it shows that the clusters of deaths were in very localized areas. So London was very big, but you ended up with very localized areas experiencing high levels of death. So here we have south of the Thames River. So that's the main river that cuts through London. That's where you had a predominant number of deaths. And to the north, you had far fewer deaths. Okay, so one of the issues that Dr. Draus noted was that the cause for cholera was unknown. And so the idea that smell had something to do with it was seen everywhere. So the diagram that I just showed you 2 slides ago showed meteorological data, so temperature, and all sorts of atmospheric characteristics associated with the spread of cholera. And so here you've got a map from the parish of Bethnal Green, which is just northeast of the downtown center of London. And this was a relatively impoverished parts of London. The average life expectancy for a worker was around 16. So once you got your driver's license, you were dead. So this was something that it was a very poor, filthy place, and it was always filled with smog. And so this is a map that shows cholera mist. So already we're propagating an idea that this must be something that we're breathing. There was an association between where people lived, their short life expectancy, and the fact that the air quality was really poor. They then, to sort of draw up this convincing story to confirm miasma, they started to connect where these deaths happened elevation-wise. And so they noted that there's a much higher probability of dying if you were closer to the Thames River than if you were much farther away from Thames River at a higher altitude. So the diagram that's on your screen now shows at the very base that if you were at an elevation of 0 or right up against the Thames River, around 176 out of 10,000 people would succumb to cholera. But if you lived at a much higher altitude, maybe 7 out of 10,000. In fact, in some areas it was 0. So this was very convincing because along the Thames River, which happens to be the low spot on the landscape, the urban landscape, this is also where you would have all of your air pollution sort of collect. The dense air sits along the river. And so you end up with that diagram, that map that I just showed you that has all of that blue area is adjacent to the Thames River. So the idea of miasma, you could find something that was correlated spatially, but it didn't necessarily mean causation. And so this is where John Snow's work came in. And so he was very interested in cholera. This was a man that lived a very fascinating life. He was an extremely talented doctor, to the point where he was asked to visit the Queen and help her give birth to their 8th child, and did so successfully. So this was a really well-known doctor. He soon realized and had a suspicion that it was polluted water, not polluted air, that was causing this. And so he was fascinated by where people got their water. So after the 1848, 1849 outbreak, he spent a lot of time trying to connect the dots, trying to connect where the death rates were highest and connect it with where people got their water from. So you can imagine that back then, people got water from different sources, different companies that were responsible for bringing water in or for piping it from underground or even from the Thames River. And so here, the southern part of the Thames River where the highest death rates were, you can see that there are two major water contribution companies, one that's in pink and one that's in blue. And then there's that sort of purple area where the two overlap. And this is the confusing part where the pipes were just sort of intertwined. And this was a really well-esteemed doctor going door to door and asking people, where do you get your water from? And then he would go to the next house and ask, where do you get your water from? And you realize very quickly most people didn't know. And that's probably still true today, where we just assume that the fresh water that comes through our tap is taken care of. But back then it was actually much trickier. So he spent a lot of time trying to develop a correlation between death rates and where people were getting their water. At that time, so in 1854, while he's designing this map and he's going, I think it's called shoe leather, boots on the ground, so he's doing a lot of investigative skills, he ends up in his neighborhood amongst an epidemic of cholera. So in 1854, a massive outbreak starting with broad streets, as Dr. Draus mentioned. And so this was a fascinating time for him to test and run an experiment right in his own neighborhood. And so while everyone was fleeing and panicking, he went door to door to ask questions about people who died in that household. And he would mark down the address, just like we would geocode a photo and post that on Google Maps. He's doing the same thing very methodically. And so he ends up with this map that starts to show these concentrations of deaths. And they seem to be centrally located around one particular pump. So here's a zoomed in version of his map that shows about 66 deaths, all within very short walking. We're talking about meters away from the actual pump. And so this led to this really famous map, this one map that changed everything with how we see the spread of disease. So we have a workhouse, for example, where lots of people worked in the center of the map, but they got their water from a completely different source, not the broad streets. And so the count of deaths was extremely low. And so he was able to ascertain the idea that, well, if everyone's drinking water from the same pump, then it's got to be the pump. No matter what the smell was, it had to be access to the water. So what I did is I took all of his data and tried to modernize it for this presentation. So this is just a basic tourist map. And you can see these little blue raindrops indicating the wells. So there were 13 pumps that people can go to and access fresh water, supposedly fresh water. And so these black dots represent all of the deaths in the neighborhoods. And just off to the south of Soho Square, Frith Streets, that's where John Snow lived. So literally this was in his backyard. And so what we can do now is check to see whether or not he was accurate with his assumption. We can look at it and say, well, if there's one pump, it's the one pump in the center of Broadwick Street. And so what I've done here is I've marked the geographic center of all of those pumps, all of those deaths. So all of those black dots, the geographic center is that red dots, which is a mere 30 steps away from the pump. So of course, Snow did not have this type of analytical technique. So he was just merely looking at the map and looking at the cluster around the pump. Around that circle, there's one, what we call standard distance. And this is 68% of all the deaths happen within that black circle, but that's also about a quarter mile away. In other words, proximity matters. And if we did this analysis for any of the other pumps, it turns out they would be too far away. They wouldn't have a lot of deaths within that circle. So the end product of this is that John Snow was able to make a difference by carefully mapping the outbreak. And we're talking about methodically going door to door, even though people were fleeing, even though people were very concerned about what they were breathing. And he finds that the one common denominator between all of the victims was one thing. No matter where they lived, even if they were passing through town, they got some pump water from the Broad Street pump and left town, they still died. And he was able to track that to the same pump. He also learns that in some places right next to the pump, they didn't use that water, and so they didn't get sick. So now he was starting to turn the tide against miasma, which was more of a popular opinion, and shift it towards something that was based on data. So he finally convinced the city to remove the pump handle. Already the data was starting to drop, but at this point, it effectively stopped the outbreak. And at this point, we started to shift towards using maps in modern epidemiology. So I'll hand this back over to Paul for the next slide, but I will say his work is absolutely essential and critical. You win lots of awards for it, but as Paul will say, one of the best things that you could ever get is a pub named after you in London. So I'll hand this back over to Paul.
Oh, thank you, Jacob. And you can probably guess from that Dr. John Snow does now have a pub named after him in London on Broadwick Street, which was formerly Broad Street. This is me in 2010. I got my picture taken in front of the John Snow pub, and this is me with a couple of colleagues. One who's a fellow sociologist, also a nurse, and the other gentleman is a professor of geography. So actually a very, both Londoners, so actually a very fitting company for this pint at the pub. But, and thank you, Dr. Napieralski, for that in-depth discussion of what Dr. Snow did. Now, what I'm going to do is sort of take that legend and complicate it a little bit. Now, one thing about that example, and the reason why we use it so much in classes, and I use it in sociology classes and medical sociology classes, and it's often used as a teaching example in epidemiology courses, which is where I first encountered it when I was taking a Principles of Epidemiology correspondence course from the Centers for Disease Control back in the 1990s. That's where I first encountered the example of the Broad Street pump and the cholera outbreak of the 1850s. It's used because it summarizes very elegantly these different dimensions of contemporary epidemiology. One, the descriptive part of epidemiology, that is who is affected, what happened to them, where were they, and when. So there's a window of time and space that's employed to understand what's going on in terms of any kind of disease spread or illness condition. And then there's an analytic dimension, which is trying to understand why and how. That is trying to go from a description of what took place to understanding what caused that to happen. So moving towards causation. And finally, there's an applied dimension, which is what do we do about it? Now that we have this description of who's affected and where, and we have a theory about why, and that theory is supported by the evidence, that gives us the means to act and to intervene so as to improve population health. And so all of those elements are contained in that map that elegant map of the Broad Street pump and the cholera cases. And so the usual story, the legend, is that Dr. Snow with this theory, and so it's really significant, Stephen Johnson in his book, The Ghost Map, actually argues against the sort of single genius idea. He talks a lot about how Snow's work actually depended upon information he got from other people in this community. So it was really about the community and learning from the community as much as it was about this sort of lone genius. But also the other part of the story, which is that they broke the handle off the pump and the epidemic stopped, is also kind of an oversimplification of what happened. In fact, as Jacob said, the epidemic, the outbreak was already starting to decrease. And there was actually another outbreak that happened later, and it was the accumulation of knowledge that enabled efficient, and actually some of the miasma theory resulted in improvements in sanitation systems in London, which were really the thing that prevented future cholera outbreaks. But I'm actually going to talk a little bit about the miasma theory and why the miasma theory actually still has a lot of validity, not for the same reasons that people believed in the 19th century, which had to do with odors and smells, but with the impact of environments and places, right? So this is a map from Chicago in the early 1990s. When I was trained as a tuberculosis control field worker in New York City in the early 1990s, and I moved back to Chicago, my hometown, where I worked as a field worker, a field-based epidemiology, doing the kind of tracking work that John Snow and his colleagues did in London. And I was very much affected at that time by a series of maps made by a guy named Stephen Whitman. And I could only find one example because these were occurred before the age of the internet, really, and everything that is not yet on Google, believe it or not, students out there. There are a lot of things, the documents that exist that aren't available on Google, believe it or not. So I was able to find this one, and actually it works pretty well because almost all of his maps looked exactly like this. This one happens to show diabetes rates in Chicago, but I used to have a book of maps made by Dr. Stephen Whitman, and they showed they were color-coded very simply, like you see here. The dark neighborhoods on the map are the ones with the higher rates of cases. And what you saw was that for almost every health condition, from HIV to heart disease to violence, to in this case, diabetes and tuberculosis, which was the disease that I was concerned with, the patterns were almost always the same. The map was almost always the same. In other words, all those conditions tended to cluster in some of the very same communities. And in my job as a public health field worker was to go and to see people who were tuberculosis patients and to find them where they were and to make sure that they took their medicine and to conduct contact investigations in those communities. And so these are some images, photographs that I took back in the 1990s of some of the settings and some of the individuals that I encountered while I was treating tuberculosis and conducting contact investigations. And this is a single room occupancy hotel. It's now been turned probably into condominiums in the South Loop of Chicago long since. But back then, this was a congregate setting where you would have had a lot of individuals of low income living in close proximity to each other. And we did a contact investigation in this hotel and found very, very high rates of tuberculosis transmission because of the air that was being shared in these confined spaces. And these are some of the patients that I worked with over over several years. This was actually in the Cook County Hospital restroom. This was on the west side of Chicago. One of my patients there in front of one of the local stores, restaurants there on West Madison Street in Chicago. And what I learned in doing this work was that even though tuberculosis, like cholera, is caused by a bacterium, and in fact, we had a treatment for tuberculosis that was effective. So we knew how to cure tuberculosis. We still had a resurgence of cases of tuberculosis in the 1990s, in part because you had concentrations of people who were vulnerable to infection, and you also had a lack of public health capacity to address the spread of that illness, right? And so I learned that an infectious disease like tuberculosis was not just about microbes. To address the disease, you couldn't just understand what microbe was causing it or how to treat it medically. You also had to understand the people, the places, and the relationships that were fueling the transmission of tuberculosis. So we talk now a lot about bending the curve. We've already had one reference to bending the curve. This diagram of tuberculosis cases from the 70s through the 90s shows you how tuberculosis cases started to surge upwards in the 1990s. And this had to do with cutbacks in public health. It also had to do with issues such as homelessness, poverty, inequality, HIV and AIDS, all that came together to create vulnerable populations that allowed tuberculosis to come back. And what you see there is that around 1992, and this is exactly the time when I started working in tuberculosis control, I'm not going to take credit for this, but you can see that through a massive effort, especially in major cities like New York City, Chicago, San Francisco, Los Angeles, we were able to bend the curve and reduce tuberculosis cases in the United States to record lows by the end of the 1990s. So that story of tuberculosis and its resurgence is in fact a public health success story that's also revealing of the enduring lessons of John Snow's investigation. In other words, through geographically understanding where disease is being transmitted and understanding also what are the factors contributing to it, with appropriate application of resources, we can in fact bend the curve and get these diseases under control and reduce the threat to our population. Which brings us to where we are today with COVID-19. So I'm going to turn the microphone over again to my colleague, Jacob, who's going to tell us a little bit about what mapping has to offer in terms of understanding what's happening now with COVID-19 globally and in the United States. And I'm going to very appropriately don my mask and exit stage left.
Thank you, Paul. Okay, so as all of you know, since you are watching this using technology, we are in the information age where information and data is readily accessible. So before the information age, as Dr. Draus mentioned earlier, epidemics and pandemics were analyzed after they were over. So the damage is done. We look at death counts and we look at casualties and we look at the damage that was done and we do everything after. And now for the first time at this scale, global, we are experiencing a pandemic and analyzing as it happens using shared global data. So we can look at daily and historic case counts as they occur and observe trends in real time, something that John Snow probably wish he could do. Remember, infectious diseases are inherently spatial. So this is where I come in. I'm very interested in spatial data. So the more aggressive the infectious disease, like COVID-19, then the more important is to rapidly acquire and disseminate the data. So one good example that probably a lot of you have interacted with or have seen on the news, this is the Johns Hopkins University dashboard. And so we use dashboards now as a way of sharing lots of different visual points of data. And so this was updated, or at least I captured this morning. So you can see the global death count, total confirmed, and then you can start to explore by state within the United States or by country. Another example of a dashboard. So again, this is data that is coming in very quickly and is posted. So this is sites that is posting very similar data, but allows you to interact with the data. So now you can look at different management practices of countries and then compare them. So on the screen, I've chosen 2 countries. One is Norway, which is where my wife is from and where I lived. And the other one is Sweden. So you probably know where I'm going with this. So Norway went to a strict lockdown in March and they spent their 6 weeks. Norway was treated like an island, no one in, no one out. Sweden, on the other hand, continued to engage and socialize. They tried to minimize a little bit, but they wanted their economy open. And so by just selecting these 2 data points, we can see a huge difference in terms of the daily counts that are occurring between Norway and Sweden, 2 neighboring countries, very similar geographies, very similar cultures, but very different management practices. So then we can start to look from more global to the United States. So obviously we're very interested in what's happening in our backyard. So this is a National Geographic map. Again, it's an interactive map. So you see in the lower left-hand corner, you can select cases or deaths. I've selected cases. And this is simply showing us the weekly change. This tells us, compared to last week, how many more cases are we either adding, or are we plateauing, or are we decreasing? Or we can do per capita or total. We can do the same thing with deaths. So you can look at Michigan, you can see that we're kind of plateauing. There's a few places where the numbers are going up and a few places where the numbers are going down. But again, in the southwest or the southeast part of the United States, that's where you see a lot of red, and that's where we see numbers going up. And so this type of data coming in on a daily basis is really informative. So we can continue to zoom in. So this is the one thing that is beneficial to having such good technology, where we're able to look at things with different scales. So here we can make observations at different scales to learn how each region may experience the peak counts at different times. And so here we have zip codes within Detroit, and we can see that not everything is distributed equally, that there are places where the counts are much higher. So then we can start to do something that is what Snow spent endless days, weeks, and hours trying to accomplish, and that's integrating multiple data sets. He wanted to look at environmental variables and compare it to where cholera deaths and illnesses were mapped. And so here we can do it very quickly. So this is, again, the city of Detroit, but it's showing hotspots of social vulnerability. So this is based on no access to car or access to public transportation, housing, poverty lines, or even vulnerable ages. And it shows pockets in Detroit where people are more vulnerable. And then it shows the breakouts in very early stages of COVID-19. So we're connecting social vulnerability to where we have a breakout of a virus. And so this is really important because it allows community organizations or the municipality to do proper emergency planning and protect populations that desperately need it. So I'll finally sign off with this one because I started with water and I'll end with water. And so this map was shared by Dr. Draus with me earlier today or yesterday. And this is simply showing the number of communities in Detroit that are losing their water. So water shutoff. So where you have bright colors of red indicate areas of water shutoff. And we think about the struggles of dealing with a pandemic or an epidemic. And that in of itself is difficult, but this begins to amplify the problem when people, as many as 15% and within a community, are losing their water. So my interest in this is our ability to integrate data from several different sources to make informed decisions. And what John Snow tried to do, and it took him a long period of time to do it, was integrate all this data. And now we can do it very quickly. We can do it at multiple scales. And that helps us react more quickly to something as big as COVID-19. So I'll hand this over to Draus to finish this. And I too will put on my mask and exit stage left.
Okay, and so now remember, I did want to give credit to this map, proper credit to Alex Hill, whose site Detroitography is the source of this map. It's a great site, detroitography.com, I believe is how you can locate it. And we will put up a lot of these sources on a page on Canvas, so those who are interested can look at them and more if you really want to get deep into this. But we want to conclude with a few words about where we are today and how this relates to John Snow and the cholera outbreak of the 1850s. And remember that idea of analytic, or of descriptive epidemiology, analytic and applied. So descriptive tells us who's affected and where, how many people in what places. The analytic, it gives us theories as to what's driving these cases and why are there more people in this place versus this place. As we saw in the Detroit maps and the connection to water shutoffs and the aging of certain populations and vulnerability of certain communities. And then the applied part is what do we do about it, right? And so of course, that's the moment that we're in here in our society today. And I want to give just a couple of poignant examples from very recent stories. One comes from Munich, Germany, and the other comes from here in Michigan. One has in Munich, which was actually very close to Italy. So they were threatened by the number of cases that were occurring in Italy back in March, right? And so they initiated a very thorough antibody screening program where they got incredible participation from their residents and were actually able to understand at a very granular level the patterns of distribution of infection in Munich, and they were able to direct resources to control the spread of COVID-19 in Munich. In Michigan, as you know, we had a different experience. We had a massive outbreak in Detroit, and we had spread throughout the city. We actually did have a pretty effective response early on in terms of social distancing and bending the curve, but we're in a phase now where we're trying to do contact tracing, and that's of course, a necessary step in terms of applied epidemiology, in terms of trying to limit spread and to break the cycle of infection. And one of the things that contact tracers are finding, I've actually been trained to do the contact tracing here as a volunteer in Michigan. And I haven't done it with my first shift yet, hopefully pretty soon. But they're finding some frustration in terms of their ability to get cooperation or compliance from the people that they're calling who have been identified as people who have been in contact with those diagnosed with COVID-19. So I just thought these were very representative quotes from each article. You can guess from which one is from which place. There was a woman that actually screamed, "I was hoping so much you guys would come to my door," because she wanted to be a part of the study. And another one, which is sometimes, the other quote, sometimes they flat out lie and say they haven't been out of the house, but you see it right there on their social media. This maybe should be in the quiz. Guess which one is which place, but I'll tell you that first example was from Munich, Germany. The second example was from here in the state of Michigan. And just a reminder, I told you the death figures for cholera, which were horrible in Haiti, 8,000 people dead, but these are the number of people that have already lost their lives to COVID-19 in the United States, 146,000. This is from a couple days ago, so no doubt this number is climbing. In Michigan, we've had about 6,000 deaths, and that's still, of course, climbing. So we're still dealing with a very serious pandemic. But what has been our response as a community, as a society? Another thing of a lesson that I take away from John Snow's example is that we need to have the bird's eye view from the data, but we also need to have the street level knowledge to be able to go after disease and limit disease. And of course, in Snow's study, he brought those two things together. And really effective public health brings those two things together, the bird's eye view, what's going on in terms of the big picture, where the cases are and what the patterns of spread are, but the street level knowledge, or what's sometimes called shoe leather epidemiology, involves knocking on doors and finding out who has been infected, who's been exposed, who needs to be treated, who needs to be quarantined, and so on. And what this map shows, and this is one that Jacob shared with me, it's actually a kind of a grading system for how well we're doing in terms of social distancing. So this is using, I think, social media data, right? It's measuring how well people are doing at limiting unnecessary trips outside of their home. And this is actually from a very recent, these grades are given on almost a daily basis. This shows that most of us, including here in Michigan, are actually getting D's or F's right now in terms of our states or our regions, in terms of practicing social distancing. I think we were doing much better a couple months ago, but this is reflecting where we are now. And of course, to some extent, we're all epidemiologists now. We've all learned the language of what it takes to flatten the curve and what we need to do as a society to bring about the result that we want, which is to get this pandemic under control, to go back to living our lives without fearing for our health or the health of our loved ones. But that requires not only science and knowledge and data, it requires commitment, it requires will, and it requires resources. And so I'm going to leave you with a quote from another 19th century physician, Rudolf Virchow, who said that medicine is a social science and politics is nothing else but medicine on a large scale. And as we move forward with this lecture series, next week you're going to learn more about the biology of COVID-19 and the epidemiology of this specific disease. But as we go forth in future weeks, you're going to learn a lot more about these social dynamics that we've touched on here today related to cholera and tuberculosis. So I want to thank you for being here with us tonight. And from us and from Dr. John Snow, please stay safe. And we have a number of resources here, and we'll post more in the Canvas site. And thank you. Again, this concludes our presentation.
Okay, thank you very much for that presentation. It was incredibly thought-provoking. So with that, we will move into the question and answer period. And we did get a lot of questions coming in, so we will just go ahead and get started. So based on the COVID-19 map data within Detroit, have there been any preliminary studies to investigate if documentation status has affected testing rates?
I'm not aware of a study particularly focused on documentation rates, which I assume means immigration rates. I do know that early data from Detroit, and we saw a map showing the prevalence of cases, actually showed that Southwest Detroit had a very, very low number of cases relative to the rest of the city. And so some people wondered as to what was the explanation for that. And one possible explanation is not that they had a fewer number of cases, but that they weren't seeking testing and those cases were not being reported. So of course, this is a constant challenge in epidemiology, as in the census, right? We can't describe a problem if we can't get good data and we can't measure what's happening. And so that's a challenge that's faced in immigrant communities, especially when there's a lack of trust with agencies that may be charged with conducting those investigations.
Well, you mentioned data, so that brings us to a really important question. I see people using the same data to make very different conclusions. So can you talk a little bit about how we can use data to come to the right conclusions?
That sounds like a good one for you.
Really?
Yeah.
Well, that's, I guess there are different ways to view that question. So we're inundated with data and inundated with maps. So I can make a map that says I can lie with a map. I can lie with statistics. And so it's very difficult to trust every single map, especially on social media, or every single data set that you hear that's being shared. So a lot of times we look at different tiers of data and what sources are deemed reliable. So these are usually federal agencies or international groups. Their data is most reliable. So if they are being cited as the contributing data source, then they tend to be more reliable than something that maybe someone is posting on social media, on Facebook, which has no link, has no supports. Then you should be a little bit more suspicious. Do you have anything you want to add?
Yeah, I would. I think it was Mark Twain who said, and maybe this was just attributed to Mark Twain, that figures don't lie, but liars figure,
Yeah,
right? And
yeah.
we say the same thing about maps. But I think an important lesson from the John Snow example and that debate about miasma versus waterborne disease, right? Of course, he didn't know about microorganisms. If you had raised the issue of microorganisms in the 19th century, people thought you were insane. And actually, that was what happened for people that originally proposed germ theory, right? So germ theory we now accept as a fact, and we don't question it. But at the time, it was seen as a kind of an outrageous idea. But you know, the miasmists were not were not wrong necessarily. So we have to remember that a lot of the data, they were actually quite adept at gathering data. It wasn't just the data that made John Snow's investigation different. It was what he did with the data and how he fused the data visualization with a theory as to what was causing the disease, right? So data can be used, the same evidence can be used to argue many, many different points. And as we saw, we can make a good argument even today that miasma is a real thing, social determinants of health that seem to be present in different communities, especially poor communities, communities of color, immigrant communities, affect all kinds of different conditions that are not related to each other in terms of biological cause, right? So you couldn't actually make a kind of a miasma argument based on that evidence. But what Snow did was he had a very specific hypothesis that he was able to credibly support, and he argued it in front of people to an extent that they were persuaded by his evidence. And of course, the conclusion to the story is usually that he was also proven by the outcomes. By when they followed his advice, the epidemics, the outbreak stopped, right? And so that can also be a good measure, right? A lot of people today, and you can jump in here, are making different arguments about whether or not COVID-19 is as real as people think it is, and whether or not wearing these masks actually makes a difference and so on. And you can look to the data and say, well, these are the places where they've done this, and these are the places where they haven't, like Norway and Sweden. And you can look at the different outcomes, and then you make a decision based on that.
Yeah, so keep in mind, the miasma theory was, I mean, they had supporting evidence. They had smog that collected in the low part of the landscape, which happened to be along the river. And the river was also where the deaths were the greatest. So you have two different data sets where John Snow thought it was the water itself, whereas the miasmans thought it was the air that they were breathing, which both collected by the water. So it forced one of those two groups to dig deeper. And that happened to be John Snow, who was desperately trying to make that connection. And so it was up to him to convince not only the politicians, but also the residents that it was the water system, not the air that they were breathing. So it usually requires that scientific process, that method to go dive into that data, to have others look at it. You have to assume that no one's going to agree with you, as John Snow did, and turn around and make a very convincing story.
You could say more, but why don't we ask another question?
Great. So you really segued nicely into another question that we received. So how do we know who to believe when it comes to pandemics, right? We hear so much conflicting advice. How can we determine which experts are worth listening to? Who are the modern day John Snows, sounding the right alarms and pointing to the correct data?
I can say that as someone that worked in public health, and I know that public health has now been politicized, like everything else seemingly in our country today. But my experience in working in public health is that it wasn't actually very political. People in public health were pretty much people that were focused on addressing very, very concrete problems using the best available methods and based on data. And they did things for the benefit of public health. And so I think when you saw Dr. Fauci emerge, I mean, many of us who worked in public health have known who Anthony Fauci is for many years. He was a leader in HIV, AIDS treatment and research, and has been a presence in the federal government in the public health sector for decades. But I think he became a national figure in part because he offered a very sort of measured, evidence-based, safety, health-oriented perspective that people found convincing. I mean, the problem is part of the world that we're living in, many of us are in different bubbles of information. And so if your experience and what you're hearing through your megaphone that you're tuned into is telling you sky is green, sky is green, sky is green, it may become persuasive that in fact is the case, that the sky is green. So I always encourage people to think critically, consider different sources of data, measure the data against outcomes, against reality. It's a confusing time that we're living in, but I think that the Dr. Snows are actually out there. There are many of them. If you start to look, you will see them. I don't know if you want to.
The only thing I'll say is it's okay if conversations about public health make you feel uncomfortable. I think a lot of Americans, if it doesn't jive, you know, they call it fear mongering, and it's really not. It's a way of preparing you for what's going to happen. And I think if we shut that down, then we won't be prepared for what happens. And I think it's important to listen to those that have that shoe leather epidemiologist that's getting all the information, not the person that's behind the counter at a Starbucks or even a news media who's just getting information. Listen to those that maybe what they have to say doesn't necessarily make you feel warm and fuzzy, but it's something that needs to be said. And I think that's how we make our best decisions. And I think sometimes the decisions have to be conservative. So as much as we want to maintain our daily routine, you know, it's common sense. You look at Norway and Sweden, two very different pathways of very similar people, and the outcome has been very different.
I mean, I would also say that the whole country learned actually a really important and a difficult lesson in terms of this idea of bending the curve. And I think there's still people struggling with the concept because it goes against our individualistic grain in the United States, where we think we're wearing these masks to protect ourselves. If I don't feel afraid, why should I have to wear a mask? When actually, the logic is entirely the opposite. You're not wearing the mask to protect yourself. You're wearing the mask to protect everyone else around you. So we are behaving in a certain way in order to limit the spread through the population as a whole. We're sort of acting as a social body and in terms of coordinating our behavior to reduce something which threatens the population, not something which necessarily threatens us individually. And so I think that's still something that's very difficult to grasp for many people, but I think the responses in this country and around the world actually show that people do grasp that sort of fundamental insight of public health, which is that it's about the health of the social body, about the health of the group, not necessarily just about, you know, your own individual protection.
Okay, our next question is about mapping. Traditional mapping is known to be quite effective, though new technology has been on the rise where cell towers can now follow the movement of people and therefore track the spread of the virus. This can provide very useful data, but at what point do the benefits outweigh the infringement on privacy? So, benefits of data collection for the sake of society or privacy?
Well, I guess I'll start on that one. So that's a great question. And I think this is where things like an outbreak of an aggressive virus brings out and politicizes a simple question of what right does a cell phone company have to track you? But the reality is you're always being tracked. So if you go missing, then they can ping your cell phone and find you. So you're always being tracked when you have a cell phone. I think there's still that desire that Americans have to share. So just because you have COVID, unless you tell someone, unless you report it, nobody knows. So the cell phone, we don't have an app that tells you have COVID-19 and immediately send it to the cloud so that we can map that. But there is information where people can self-report. There is information where people can do some very basic contact tracing where they can communicate who they were with and where they were within a certain period of time, so we can easily map that out and then send people to then communicate with those people that interacted. So almost like points on a map. You know, when we talk about social distancing, I sent Draus an email a week or two ago that because of the social distancing and the mask wearing is being somewhat controversial as well, that, you know, now they're testing the idea of on cell phones, the Bluetooth technology will ping if I get within 6 feet of Paul Draus. So this is how Paul keeps me away from him. His phone will go off when I go near him. And so some Americans, I suspect, won't like that because it takes away their individual freedom to hug Paul. And everybody wants to hug Paul. But his cell phone would go off and mine would go off. And that would help us enforce that gap. So I think there is this question of how much data do we need during an emergency? I mean, this is not a regular activity that we hope to see, but it's an emergency. It's something where we need to collect lots of data. And I think Americans have to understand that in order for us to get out of this, we need lots of really good data and we need it quickly. We need to make wise decisions. If you're talking about ordering pizza, if you're talking about something else, then yeah, certainly there might be some more privacy, but I think a lot of people do share their location more than they realize. I think they're already sharing all of their pictures. Everything that they do is being tracked. And then now when it's important that we understand who has a virus and where they've been, it suddenly becomes a significant issue. So I think to some extent, in these types of moments, we kind of shift to the conservative side and say, you know what, we need to collect as much data as possible. But at the end of the day, it still has to be the population themselves, the individuals reporting that data.
Yeah, I would say also that, I mean, it's always a bit of a trade-off when you're talking about data, but the interesting thing to me is that we tend to get alarmist, or we tend to get wary about institutions collecting data like the Census Bureau or the Health Department and things like that. And these are actually institutions that are accountable to us, right? They have rules that govern what they can do and what they can use data for. Same thing at a university. If I gather data from people, there are very strict rules I have to follow. If you saw the presentation last week from Dr. Terry Laws about the history of the Tuskegee study and so on, we now have, as a result in part of unethical studies done in public health and medicine in the past, we actually have very strict rules and protections. And so those actually they make a difference. I'm actually one of the people that feels that this pandemic has revealed to us not how our institutions have failed, but actually how valuable our institutions are and how much we need to invest in them while at the same time keeping them democratic and accountable. Because the funny thing is that people will be alarmed about or wary about giving data to the Census Bureau, who de-identifies all the data and doesn't connect it to individuals at all, but they give away everything on Twitter or on Facebook. And Twitter, none of your data on Twitter is secured at all, right? In fact, police departments use Twitter data very regularly to identify potential threats in terms of violence, for example. So that to me is a kind of interesting paradox, it seems like. But again, it is all this attention, and the one map that we showed, that Jacob shared with me and we put in the presentation, showed how your cellular providers are in fact looking at this data very, very deliberately. In fact, they have an activity called data mining, which is all about trying to use all of this big data to understand our preferences and our patterns. Much of that for the purpose of trying to sell us goods and services, as opposed to trying to protect us, right? And so I think we need to be able to make that distinction and see it as one that's actually legitimate and meaningful.
Okay, so not related to the miasma cholera case, have there been events or epidemics in history where there was a major resistance or almost rebellion, you might say, put forth by people across the world who didn't want to follow the rules, such as social distancing or wearing masks, because they didn't believe in its effectiveness? And what were the consequences?
Unfortunately, that's a pretty easy one, because that happened in about 100 years ago in the 1918 Spanish flu epidemic, where, like what we're experiencing now, it went through several phases. There was an initial outbreak, I believe, in the spring. It died down somewhat, and you had a number of cities where rules and protections were relaxed. And you also had people that were resisting wearing masks and many of the things that we're seeing today. And then following that, you had actually, there's a very interesting, I don't know if you've looked at this, Jacob, there's sort of a natural experiment that was conducted between two cities. I think it was Philadelphia and St. Louis, where one city kept all these rules in place, where they wouldn't allow people to go outside. They were practicing what we today call social distancing, sheltering at home and so on. And the other city, I believe it was St. Louis, and forgive me if I'm getting them mixed up right now, I'm blaming the wrong city. They decided to go ahead and open up. They had a parade. They did they said they're going to celebrate. And they actually had, after that, a huge resurgence of Spanish flu. And of course, the Spanish flu, I can't recall the death numbers on the Spanish flu in 1918, but they were really, they were in the millions worldwide. So unfortunately, we have a pretty vivid example in our own history. I'm sure, we could talk about vaccinations. That's a whole other sort of issue that we have in the United States around resistance to vaccinations, which, again, pits the sort of the individual concern for health and risk against population health concerns. The purpose of vaccinations is, of course, to protect the group. not necessarily to protect the individual, because when you have herd immunity, and we're all become familiar with that term now, I think, which vaccinations can produce, it makes it very difficult for an infectious agent to move through a population. And when you have pockets of people who are not vaccinated, who don't have immunity, that creates a clear path for infectious agents to move through a population. So, I mean, those are a couple of examples I can think of where we see this resistance, as you're saying. And, you know, I'm not someone who's opposed to resistance. I think there are lots of things we should resist. And there are sometimes very good grounds for resisting. You know, public health can be abused. Public health powers can be abused. So we need to always be on the alert. We need to ask critical questions. But again, public health is often about balancing the welfare of the whole versus, you know, sort of the interests of the individual. And I think that's been one of the big lessons here in the COVID-19 pandemic. And I think Governor Cuomo is sort of fond of saying, you know, not me, we, right? I mean, this is really what we're trying to think about here. And let's face it, for a lot of us, that's a stretch in the United States.
Okay, so kind of along those lines, what do you think are some logical steps that people can take to help others be more comfortable to contact tracing, if that is really a measure that is needed and there is some resistance? What are people's fears about that, and how could those be alleviated?
I think that, again, I was supposed to do a contact tracing shift on Friday, and my login ID had not been approved by the state yet, so I wasn't able to do it on Friday. I was hoping to have some firsthand experience with COVID-19 contact tracing. Of course, I'd done contact tracing relative to tuberculosis in the past, and I think that you know, in public health, one of the things I learned is that building relationships with people, right, whether at the individual level or at the community level, always pays dividends in the long run, right? And so there are people who are going to be suspicious when you call to ask them questions, and they have a right to be, right? People have a right to refuse, right? But I think it's incumbent on public health officials and people working in that capacity to be patient, to be persistent, to use persuasion, not to resort to threats or accusations. When I started working in tuberculosis control, and I asked one of my supervisors about, you know, how do we get people to do what we want them to do, right? And you know, is there somebody I can call if they disobey, right? If I say take your medicine and they say no, I'm not going to take my medicine. He said, well, you know, actually, patience, persistence, and the powers of persuasion are pretty much our tools that we have to use, right? But one thing I did find is that when you build relationships with people, when you treat them with respect, the people will tend to cooperate more times than not. I think one of the challenges with COVID-19 contact tracing is that a lot of this is being done over the phone, you know, because everything's being done virtually and at a distance. It seems pretty abstract. The contacts to people can be pretty fleeting, and so I think people might have suspicions about who's reported them because you're not telling the person when you're calling them who it was that had COVID-19. And so I think there are a lot of challenges sort of specific to COVID-19 that we still have to work through, but it really requires investment in basically the human skills, you know, the social capital to be able to do those jobs, because we think it's something that's mindless and brainless. Pick up a phone, call somebody up, ask them how many people were you around, and write it down and tell them what to do. But in fact, that actually requires a lot of skill to try to get people to cooperate, even something very, very simple. And that was one thing I learned in my years doing tuberculosis control, that getting people to do something extremely simple, such as take a pill that's needed to save their lives, can actually be a quite challenging thing, depending on what else they have facing them that day. That's another thing we have to remember, is that a lot of people, especially people in communities very much afflicted by COVID-19, and poor populations, people who are struggling just to make it, they have a lot of other pressing concerns oftentimes. And this may not be the first thing on their priority list, even though it's your first thing on your priority list as a public health worker or as a public health agency. So those are things just in general that I would advise or offer.
Yeah, I think it's also important to reassure people what's happening to the data. I think a lot of people are concerned about who has access to the details of the data, just like the US Census. And it's important that they're told that it's serving a very significant purpose, but then it's aggregated. So I can't go out and get personal data about anyone reporting anything about COVID-19. That's usually aggregated to the zip code, to the census tract, so a much larger area, just like the census that has very strict rules. I think people get really concerned about what happens to data. So when it's a one-on-one interview, I think reassuring people that the data serves a broad purpose, but is not going to be shared as a discrete feature or sold to anyone, that is not what is supposed to be happening.
I think one thing we've learned from studies of health behavior, my colleagues in public health who work in health education and health behavior, there's one thing we learned during the HIV epidemic is that shaking a finger at people and telling them you shouldn't do that, or we learned from the drug campaigns, don't just say no, drugs are bad for you, don't do that, you'll be a bad person. That actually doesn't work. In terms of, in other words, a punitive approach or a judgmental approach tends not to work in terms of assuring compliance in public health. It's much better to be open, honest, cooperative, and respectful in all interactions.
Okay, well, given our time, this is going to be our last question for this evening. It seems that a lot of the map data we see is created solely to spread information to the public to see how COVID is getting worse and at times creates more panic in communities. How are government agencies such as the CDC using map data to lower the curve and stop the spread, knowing that such data might add to panic?
I heard maps in there, so I think
So I think if I understand the question was, how can we use data to not scare people? Is that kind of?
Yeah, I think what the question is getting at is oftentimes maps are used as a way to share how bad things are, but how could maps be repurposed to be part of a solution that isn't quite as scary? So, the way I heard that question was, could maps show progress or show positive information more and not just be about scaring people?
Well, I mean, obviously, so we can use maps to show death counts, or we can use maps to show recovery counts or not afflicted accounts. And if we did that, if we showed a map that showed the people not afflicted by COVID-19, we would feel really good about ourselves, but the map would be somewhat deceitful because the focus is on the spread of the disease itself. So yeah, I think that's certainly something that people have to accept, that sometimes when you look at data, you will feel uncomfortable, but we have to learn lessons from that. The example of Norway and Sweden is a perfect example, two countries that handled it very different. You get a warm, fuzzy feeling when you see Norway and their response, but they had to go through that strict shutdown, shut the borders down, and now their daily count is about 0. So the data makes you feel really good. When you look at Sweden's, that looks like someone's heart rate when they go in to do a blood draw. It's all over the place. You have lots of daily counts one day, and that decreases the next day, and so on. And so you have two totally different, one that makes you feel sad, one that makes you feel happy. But the point is that one country followed very strict social distancing, masks, and in essence, demobilized the population, while the other one chose not to. And I think that's the important part, is even if the data doesn't really make us feel good, I think it's, even if it shows that there are some issues, or that there are issues that are on their way, that we could be better prepared and minimize that impact long-term.
Yeah, and I would add to that in sociology and in public health, we talk about sometimes the importance of doing asset mapping as well as what we might call deficit mapping. In other words, not just sort of using maps to show where the problems are and what the sources of those problems are, but also using maps to show where the strengths are, where sort of maybe good things are happening, or where deliberate action in the case of public health is making a difference. And so I think of the country of Rwanda in Central East Africa, which actually has been sort of very successful in preventing a COVID outbreak or epidemic from occurring there, even though neighboring countries have struggled with that. And partially it has to do with the status of their government institutions and their populations sort of willingness to go along with the recommendations put forth by that government. And so, yeah, so maps can be used. It's one thing that Jacob and I have been collaborating on a number of different research projects, and that's, one of the things we're always sort of trying to get right is like, what story do we really want to tell? I mean, what do we want the map to show? And it's not, going back to the question about, you can use data to show a lot of different things, to argue one thing versus arguing another. So it's not about sort of, trying to twist the data to distort it, but it's trying to say like, look, we want to emphasize certain things that are happening, and how can we use maps and data put in the form of maps to show that to people? Because the one advantage that maps have, and I think we saw that in John Snow's study, is that visually we're spatial creatures, right? We mark our identity by our surroundings and our location. That's where the river is, that's where the pub is, right? And when you put data into the form of a map, it really makes a lot of intuitive sense to people. It becomes a very, very powerful tool, and it's a powerful tool that can be used to communicate a lot of different things. And so hopefully that's one of the things that we were able to show here tonight.
Great, thank you. So that concludes the formal part of tonight's presentation. I'd just like to spend a few minutes going over some housekeeping details briefly. So the link that you used to access tonight's presentation will be the link that you will use each week for our course. It's the same link that you used last week as well. All presentations will be recorded, and those presentations will be uploaded to the Pandemic's Perspective website likely tomorrow. You'll see that the first presentation from Dr. Terry Laws is there on the website if you were not able to join us last week. And then in the Canvas site for students, you'll find a 5-question quiz that has opened up. Please be sure to take the quiz no later than next Monday night at 11:59 p.m. And as a reminder, to earn the credit, you must participate in our sessions, complete the quizzes, and then complete a reflection assignment, which will be given at the end of our time together. And lastly, I just want to invite everyone, whether you're here for a credit or not, to continue and join us again next week. Next week, we'll be joined by Dr. Raji Janakiraman. If you've ever wondered, what is a virus? What is the virus that causes COVID-19, and why is it so dangerous? And how did COVID-19 become a pandemic? Then you'll want to tune in next week for Dr. Raji's talk, Epidemiology of COVID-19. Do join us. Thanks again for being here this evening, and special thanks again to the team who's been working diligently for weeks to put this all together. We hope you have a great week, and we will see you next Tuesday. Good night.